Hi, I'm Dr. Randy Martin. We're here at AATS Mitral Conclave 2017. I'm thrilled to be joined by Dr. Fred Mohr. Fred, you really need no introduction to our audience, but you've made tremendous contributions by not only your skill, but your academic integrity and all that. I want you, because you've been such a leader for so many years, I want you to put on your futuristic hat. Where are we going in the mitral space over the next 10 plus years?
Let me just look back 20 years.
Okay.
We have started the minimal invasive mitral valve surgery about 20 years ago, and it has grown and grown. And in Germany, for example, 70% of the mitral valve operations are done by minimal invasive endoscopic surgeries. America hasn't taken up in that speed. I think you're at 30%, so there is still some growth. On the other hand, we have the catheter-based techniques like the E-valve for the cardio band upcoming, and it is interesting that these technologies, despite the fact that they don't have a perfect result in terms of a perfect echo, no regurg, they still have an impact on the patients. They do better, and of course, the procedure is with a lower risk than the surgical procedure. I just recently attended a meeting in Zurich, just focusing on mitral valve surgery, and especially on the catheter-based techniques, both for mitral valve repair and replacement.
Okay.
It was interesting. It is like a revolution that so many companies are focusing on catheter-based mitral valve replacement, which was surprising for me. There are some surgeons already involved, like Maisano in Zurich and Volkmar Falk in Berlin, and his team and our team and Thomas Walter have started in the experimental way. I'm pretty sure that many of the as yet surgical operations will be done by catheter techniques.
So you think that there will be an evolution where transcatheter techniques will occur in the mitral space?
Yeah, I think so. There are so many devices right now in the experimental evolution, and I think some of these devices may find a place, especially in those patients who suffer from functional mitral regurgitation.
Okay.
It's a different story if we talk about rheumatic disease. Those patients have a very narrow left ventricular outflow tract, and this will be extremely complicated.
What about in primary MR and degenerative? You think? I mean, there's some, obviously, this beating heart neocord stuff and harpoon.
There is a neocord which is introduced quite successfully, and also the clip has been used for P2 prolapses in many cases quite successfully. Fortunately, at least on the European side, it's also in the hands of the surgeon. So it has to be a hard team decision. A cardiologist wants to be, at least in Germany, wants to perform. He has to have a discussion with the surgeon, and the surgeon has to agree. And for example, in my team, 3 of the younger surgeons are performing these catheter-based techniques both on the mitral and the aortic.
So Fred, that leads me to the question, I mean, and obviously in Germany I know that the surgeons have been the leaders in the TAVR and now in the mitral space. How do we train the surgeon of the future? I mean, I'm old school and thinking I'd love to have a surgeon that knows how to still operate, but how do you train the...
I think cardiac surgery has to centralize. We have to have centers with a larger volume, and of course everybody has to go through a general training, which includes the cath lab training. And after that, everybody has to decide, I'm going to focus on this or that part, and develop some excellence in terms of structural heart disease, for example. He should be able to perform the surgery and also be able to do the catheter-based techniques. And for me, it is no question that cardiologists and surgeons, if they want to succeed, have to work together.
And I understand that. What I'm asking is do you see, so let's say in Leipzig, that you see that you'll have surgeons that will specialize in mitral and tricuspid, and they'll be predominantly interventional transcatheter versus the surgical, the traditional surgical approach, or they just need to be trained in both and be competent in both?
I think they should be competent in both.
Good.
Yeah. As long as the volume is big enough, and in our center we can provide the volume, and they have very good training both in the surgical and the catheter-based technique.
Listen, Fred, you've run one of you and Mike Mack have run one of the biggest meetings in the world, one of the most innovative surgical meetings, and certainly the Mitral Conclave fits into that family of innovative meetings. Thank you very much for joining us.
Well, thank you. I'd like to invite you for the next meeting. It's
I'll have to come.
Guided by Michael Mack, and EX actually is going to taking it over, and the European Association is like here. The AATS EX will be the
parent
of these meetings, which is very important because the financial issues in 2080 because of EUCOMET have a major impact on how you can organize meetings.
Absolutely, absolutely, and it was, of course, which we have there. But thank you again for joining us.
It's thank you for this talk. Thank you very much.
And thank you all for joining us. It's great to have you, and come back.